Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. Today's episode is part of an ongoing series of addressing misunderstandings in applying HBV treatment guidelines. This series features brief conversations between a physician and a patient in which they discuss ways to collaborate in care and reach shared decisions, often describing their own experiences. In this episode, Dr. Ming-Lung Yu, Chair and Professor in the Hepatobiliary Division, Department of Internal Medicine and Hepatitis Center at Kaohsiung Medical University, and visiting staff in the Hepatobiliary Division in the Department of Internal Medicine at Kaohsiung Medical University Hospital in Kaohsiung City, Taiwan, has a conversation with his patient on the risk of hepatocellular carcinoma in patients with hepatitis B and the importance of screening and early detection of HCC. He had a conversation with the patient in the patient's native language, and for this podcast, you'll hear our producer reading the patient's answers in English. For more information about Dr. Yu and for a link to additional online education on this topic and more, please visit the link in the show notes. To Dr. Yu and our patient, thank you so much for joining me today, and with that, I'll turn it over to Dr. Yu.
Good day, ladies and gentlemen. I am Dr. Ming-Lung Yu from Kaohsiung Medical University, Kaohsiung, Taiwan. Today, my patient, Ms. Huang. She is currently 45 years old, female, and we are going to have a CCO infectious special grant under the misunderstanding of HBV guidelines. So, Ms. Huang, do you know you are a hepatitis B virus carrier? And do you know your risk factors of liver cancer? How you were educated on what risk factors you have and how the risk factor change over time?
I didn't know I had hepatitis B at first, but when I was pregnant, I had a blood test and found out I had it. At that time, I thought that hepatitis B was quite common in Taiwan, so I didn't pay much attention to this. But later, until my elder brother developed liver cancer, did we realize that hepatitis B can cause liver cancer and that the risk is very high. The doctor then told us about the importance of regular checkups, so we were asked to have all our siblings come in for checkups, and we all had regular checkups.
So, Ms. Wang just stated that he knew his HBV infection at the screening when she was pregnant, and later on, she found that his brother suffered from the episode of hepatocellular carcinoma, and he was also a HBV carrier. So the point is that who are at the risk of hepatocellular carcinoma with HBV infection? We all know that the risk of HCC is 15 to 20 times greater among HBV-infected individuals compared with those without HBV infection. And especially in Asia, where HBV is endemic, 60% of liver cancer is associated with HBV. The lifetime risk of HCC among chronic HBV infection is estimated to be around 15 to 25%. And cirrhosis is the single largest risk for developing HCC among this patient population, around 2 to 3% every year. The other risk factor for the liver cancer in HBV infected patients without cirrhosis, including the male sex, the old age, Asian or African ancestry, family history of HCC in first degree relatives, obesity, diabetes. For example, for non-cirrhotic HBV patients, Asian males greater than 40 years old and Asian female greater than 50 years old are at a higher risk of liver cancer. In addition, persistently positive for HBe antigen high levels of HBe replication that, for example, HBV DNA greater than 2,000 IU per mil, or surface antigen titer greater than 100 IU per mil, longer duration of infection, co-infection with the other virus such as HIV, HCV, or HBV are all at the higher risk of liver cancer. In addition, if the patient continue to exposure to the aflatoxin or continue to having drinker, they are all at high risk of HCC. So at the first presentation of my clinic in year 2000, Ms. Huang was less than 30 years old, the antigen positive with normal liver function, and no evidence of advanced fibrosis by ultrasound sonography. And however, her mother and siblings were all HBV carriers. Her mother and brother would die of HBV-related hepatocellular carcinoma. So the data indicate that Ms. Huang's HBV infection was in immune tolerance phase at the time. So there's no benefit from the antiviral therapy. However, she was at the risk of hepatocellular carcinoma because of family history of liver cancer in her first-degree relatives, as well as persistently positive for E antigen in the following years. Therefore, regular follow-up with surveillance of liver cancer is advised for Ms. Huang. And in early 2010, she experienced a short period of mild abnormal liver function test with rapid decline of HBV DNA, and most times below 2,000 IU per ml, and the E antigen loss become anti-HBe seroconversion, indicate her HBV infection turned into the inactive phase. Although current guideline does not recommend antiviral therapy for HBV patients in inactive phase, regular follow-up with surveillance of liver cancer remain recommended for Ms. Huang because of her family history with liver cancer. Well, the second question I would like to ask Ms. Huang is that what types of HBV surveillance do you have? Did you need further work-up based on US HCC surveillance?
I know I have them every 3 months or 6 months. Previously, it was conducted every 6 months, but later it was changed to every 3 months. I will check the GOT, GPT, the alpha fetoprotein test, and the ultrasound to monitor if I have any abnormalities. When an abnormality was found, the doctor performed an ultrasound as well as a CT scan and later an MRI, which revealed that I had liver cancer.
Yeah, exactly. So the APASO, the Asia Pacific Association for the Study of Liver, consensus recommendation on HCC recommended ultrasound sonography and alpha fetoprotein every 6 months as surveillance test for hepatocellular carcinoma. Surveillance of HCC is recommended in high-risk population with chronic HBV infection such as Ms. Huang, and current HCC risk prediction score can accurately stratify the risk of HCC in patients with chronic HBV infection and could be used to determine the target population for surveillance. For example, the RISC-B score composed of male sex, age, ALT, level, E antigen status, can make a 17-point risk score, which could predict the patient at high risk of hepatocellular carcinoma very well. Surveillance of liver cancer should be performed by ultrasound sonography and alpha fetoprotein every 6 months, and preferably every 3 months if the patient has liver cirrhosis. And then contrast-enhanced dynamic compute tomography or dynamic magnetic resonance imaging (MRI) should be used regularly for confirmation for suspension lesion and ultrasound sonography screening, or for patients with advanced fibrosis with high suspicions of development of hepatocellular carcinoma. Therefore, the Ms. Huang continued to receive regular surveillance of hepatocellular carcinoma with ultrasound sonography every 6 months and alpha fetoprotein every 3 months after E antigen seroconversion in 2013. Because her HBV DNA fluctuated around the 2,000 IU per ml and her family history of hepatocellular carcinoma. Unfortunately, in 2018, her ultrasound sonography disclosed a small nodule in segment 8, despite the normal alpha fetoprotein levels. Therefore, I arranged a dynamic image MRI for her. Okay, let's go into the last question in this section. Ms. Huang, do you know how you were diagnosed with liver cancer and what your journey has been since HCC diagnosis?
In a regular checkup, the physician in charge of ultrasound found a dark shadow during the ultrasound. Considering there may be an abnormality, he asked me to go back to see Dr. Yu for a diagnosis. When I went back, Dr. Yu told me that he would run some tests on me. I am very grateful to Dr. Yu for diagnosing me with an ultrasound because I thought it was quite important. I had a CT and an MRI, but the image of the MRI was benign. Fortunately, Dr. Yu did an ultrasound for me and confirmed that it was malignant, so I was able to follow up very smoothly, proclaim it as liver cancer, and then go through the operation. After being confirmed to have liver cancer, I really had a tough time and felt very sad. How can I put it? I cried for a long time over this matter, so what can I say? My mood had certainly changed. After treatment, though, I think it is good for us to treat it as a chronic disease, that is, to have regular checkups, and then to come back on time to visit the physician. In other words, it is better for us to have early detection and early treatment.
So the typical liver cancer, hepatocellular carcinoma, can be diagnosed by imaging regardless of its size. If a typical vascular pattern, such as the arterial enhancement with portal venous washout, is obtained on dynamic CT, dynamic MRI, or ultrasound contrast echo. However, some nodules do not have the typical vascular pattern. So the nodule lesion that show an atypical imaging pattern, such as ISO or hypovascular in the artery phase or arterial hypervascularity along without the portal venous washout, should undergo further examination. Since Ms. Huang's dynamic MRI shows a typical pattern, so I just suggested her to receive tumor aspiration for diagnosis, which confirmed that she got a well-differentiated hepatocellular carcinoma, and her HCC stage is BCLC stage 0, the very early HCC stage. So many curative therapy, such as surgery, surgical resection, or radiofrequency ablation, can be applied for her early cancer. And previous studies have demonstrated that the patients with high serum HBV viral load at the time of tumor resection show a significantly higher recurrence rate compared with a patient with a low viral load. And also another study demonstrated that nucleoside or nucleotide analogs had been effective in reducing the risk of recurrent HBV-related HCC and could prolong the survival of patients after curative therapy in large-scale population study in Taiwan. Therefore, I recommend Ms. Huang study to receive oral antiviral therapy and take cover 0.25 milligram per day, and recently switched to tenofovir anafenamide due to the reimbursement. And we hope that the continuous viral suppression will have a long-term benefit for her HBV infection, as well as to reduce the risk of HCC recurrence. So, ladies and gentlemen, patients with chronic HBV infections, while they may meet the criteria for antiviral therapy or not, should receive regular surveillance for liver cancer before ultrasound sonography and alpha beta protein every 6 months. If they have a risk factor of HCC, such as Asian male greater than 40 years old, Asian female greater than 50 years old, family history of hepatocellular carcinoma, and persistently high HBV replication status, etc. Regular surveillance could help us to detect the liver cancer at the earlier stage and let us have a chance to cure the tumor for our patients. Antiviral therapy of HBV after curative therapy could reduce the risk of tumor recurrence and improve patient survival. Thank you very much for your attention.
Thanks to Dr. Yu and to our patient for sharing that conversation with us. And thank you to our listeners for joining in. As a reminder, if you would like to hear short presentations on additional topics related to the care of patients with hepatitis B, I invite you to visit the Clinical Care Options website by clicking on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.